Hi, everyone, and welcome. Thank you for joining us at this new later time. I do see some folks who haven't often made it, so would love to hear from you in the chat if the reason you're here is because of a more convenient time, because this is going to be a pilot for the next few months, and then we'll try to make a decision as to whether 12 or 12:30 is a better time for all of the folks who are participating. So if you want to just message me and or Summer and let us know, that would be super helpful. We really appreciate it. Welcome to everybody. Hope you're having a good Wednesday. And I am so pleased to have Dr. Pia Francisco back. Dr. Francisco has given us at least 2 or 3 prior ECHO talks, all of which have been amazing. And so, adolescent is definitely an area of weakness for me. And I always feel like I can learn so much from hanging out with Dr. Francisco and, caring for patients with her together. What I'm excited to see is that we've got like a variety of topics on the menu today, and it's going to be really nice to get the high points of some really important updates, and we're looking forward to hearing what you have to share with us. So as usual, I will take a look at the chat and just sort of interrupt if there's anything that needs like right away clarification or a question just in the moment. Otherwise, we should have some time for questions, comments, and or discussion of patients at the end. And without further ado, I will hand it over to Dr. Francisco and look forward to learning together. Thank you all.
Okay. All right. Hi, everyone. I'm Pia Francisco-Natanauan, Adolescent Medicine. Thank you to Pediatric for the invitation. I have nothing to disclose financially. We've gone over the objectives. Sometimes I think that I'm a broken record to myself. So there are no silly questions. I can talk so much, so I'm gonna keep it brief so we can, if you have further questions, we would want to make sure that they're addressed. I'll start off with some statistics. Disordered eating in Hawaii is not uncommon, as opposed to what I have been told when I took this position, quite honestly. And by race, what is scary to me is that the eating disorder, this is disordered eating by race or ethnicity. We have on the top of the list, Pacific Islanders, followed by others, and the others is like a mix of everyone, and then Filipinos and Native Hawaiians. So that's everyone, I think, in this in the room. Okay. More common in females, not surprisingly, but again, also not surprising if a person identifies LGBTQI+, you can have disordered eating. By definition, eating disorders are a mental disorder. Like, why would I send it to adolescent medicine? It says psychiatric condition. That is correct. And according to DSM-5, it's the persistent disturbance of eating or any eating-related issue, behavior that results in altered consumption of food, and then it significantly impairs the well-being of that person. If you go to other states, the diagnosis of the eating disorder can only be provided by a psychiatrist. So I think in Hawaii, at least we can actually really get that diagnosis even for as common practitioners. Okay. Other disorders, eating disorders in DSM-5, you have a whole list. What I want you to note about this is that they all can be resolved with nutrition. So try not to feel helpless whenever you're encountering, oh, I'm sensing this is an eating disorder. It's so hard to get them to see a mental health provider. How can I have them see one? The resources are not available. As a medical clinician, as a medical provider, you have the ability to get them to know that, hey, you got to get food in, because eating disorders are deadly based on nutritional insufficiency. Okay. The clinical features of common eating disorders are the following. If you like tables, I provided one for you. I'm very proud of this table. But anorexia nervosa, the classic kind, you will have low body weight, what they call, I say they call atypical anorexia nervosa, because to me, it's still anorexia nervosa. If your body weight is normal, but then you can't really gain the weight. If you're not gaining the weight, or the growth chart is plateauing, that's weight loss, equivalent to weight loss. Bulimia nervosa, you can have normal, overweight, or obese. Same with binge eating disorder. The difference between the two, binge eating, you don't have that compensatory behavior to get rid of that food. It just sits there. Oh, I want to eat. I feel comfortable. I'm going to eat a lot. And then you don't get rid of it. Bulimia nervosa, when you get rid of it, it's a compulsion. It's not limited to throwing up. Could be with excessive exercise, or use of medications or laxatives. Avoidant restrictive food intake disorder. These are, to me, I think, the kids who cannot just like expand their variety of food, and then worse is that they can't really eat, or they're throwing it up. Okay, oftentimes you would have a low body weight on this individual. How about those ones that are not forthcoming? I really just can't eat. Oftentimes that would be anorexia or atypical anorexia. It's very rare that would be avoidant restricted food intake disorder. I'm going to say ARFID for this because it's a mouthful. ARFID, usually you'll see that in patients who are in the autism spectrum, or maybe they've had like a very high anxiety because they had a very unpleasant experience with food. In the literature, patients with ARFID who were diagnosed young with ARFID, oftentimes they half the time they would end up being diagnosed with atypical anorexia nervosa, or maybe anorexia nervosa too. So it's very, it's fewer to see that it's true ARFID. Pica, I've never seen this in practice in terms of adolescents. I would see this in adults, but it is an eating disorder. Adolescents are very prone to body dissatisfaction because they're going through puberty. They're very self-conscious about how their body looks. And the studies that are out there, it's more commonly seen now how non-Western individuals growing up in Western societies would report the body dissatisfaction. And this goes in line with the stats I've shown earlier. How do we know if this is gender dysphoria versus body dysmorphia? I think this slide is like roughly, because you really need the element of time. Yeah, dysphoria would be there's no body distortion. Like if this person were identifying in terms of gender identity, it's opposite of what they're seeing on their body. That's dysphoria. Dysmorphia, as in when you have the body dissatisfaction, eating disorders, they have a different view of their bodies. Like they're almost always dissatisfied with it. Males with eating disorders, I dedicate always a slide because it's still often underdiagnosed, but they have a higher risk of osteoporosis, and this is because of the low sex hormones. And when you're losing weight and you have low weight, then there's no weight-bearing component for the bones. I put decreased libido. Sometimes when I talk to my male patients about dating or sex drive, that helps them get motivated. They don't realize it because nobody talks to them about it. Yeah. And oftentimes that could be a sign actually of depression. So for males who have lost the weight, I have a very low threshold of checking sex hormone levels and vitamin D levels because of their bone health. I try to motivate them, or maybe look into, okay, dating and see how that is affected. Relative energy deficiency in sport. Don't we love, I'm joking about this, but there's so many acronyms in the world. But okay, this is Red S. It used to be female athlete triad. They try not to use the acronym because it's fat, ironically. But this is the combination of disordered eating. And actually, I want to say, because it exists in males too. Disordered eating, periods, stopping, osteoporosis, and like with the previous slide, it's because of the low hormones, particularly estrogen. The treatment when you have a patient with secondary amenorrhea and disordered eating and decreased bone mineral density. It's nutrition to weight restoration, not like menopausal women that you would have to treat with bisphosphonates. Sure, they can take calcium supplement or maybe hormone replacement, but that would be kind of like a Band-Aid treatment for that. Hormone replacement therapy, should this happen for your patient, the results are not consistent. The only thing that's consistent would be when you get the patient to be weight restored from nutrition, then they actually resolve the decreased bone mineral density. Menses, if you have a female patient, menses is a vital sign. So if they're reporting irregular bleeding, or my periods are getting lighter, or they actually stopped, do check hormones and check osteoporosis. Not oftentimes, I always tell my patients with eating disorders, the weight is a moving target. I actually don't discuss numbers with the patient. But if you're a female, getting your periods back is a golden sign that physiologically your body's there. And the energy deficit is probably resolved, but you can't just stop at one period. You got to have at least 3 consecutive cycles to see that your body's actually, okay, I have normal sex hormone levels, reproductive system is back to work. And when you have normal levels of your sex hormones, then bone mineral density can be back to where it needs to be. Bradycardia from malnutrition or nutritional insufficiency, and then you get, okay, well, we're all athletic, that's why we have a slow heart rate. Bradycardia from malnutrition, you would have an orthostatic differential widening, possibly, or sometimes it's not even recovering. The difference to the athletic heart is that when you have an athletic heart, there's no compensatory increase in the heart rate when you're checking orthostatic vitals. But do know that even if you have bradycardia and it's because your patient is an athlete is really also at risk for having eating disorders. Okay. Nutritional insufficiency, I think this term is more really Western in the sense, because when you have nutritional insufficiency, it's malnutrition. But when you say malnutrition, people think developing country kind of malnutrition, maybe kwashiorkor, maybe marasmus. When we say eating disorder, it almost always seems a mental health disorder, right? So what I want you to remember, if you forget about everything else because of the amount of talking I'm doing, the patient you have who has an eating disorder will have malnutrition. And the way to go about it is to treat that nutritional deficiency. You have weight loss. When you have weight loss, you have micronutrient deficiencies. You have multi-organ system problem or failure. You check the BMI, look into their dietary recall, and the amount of energy that they're spending. And then definitely check their vital signs. How our bodies respond to malnutrition is that it will protect itself in a state of starvation. The metabolism will decrease. You will have hypothermia. Your heart rate, your blood pressure will decrease. And interestingly, if you have someone who you might expect tachycardia in someone who's been starved or undernourished, but this is almost to the point of like, okay, the body's really trying to conserve the energy because it doesn't have a lot of resources. It's like hibernation almost. Yeah, so everything would slow down. When you're dealing with malnutrition, all systems will be affected, maybe not all at the same time, but constitutionally, you have arrested growth or maybe underweight, mentioned hypothermia, cardiovascular changes. This is a variety. And, when we have these things, oftentimes, actually, these are the things that would send the patient to the emergency room or maybe even be admitted to the hospital. The other signs you will see as outpatient. Their periods are slowing down. Their gut slows down. They have constipation. Maybe you'll have blood work and you'll have some like vague abnormalities. Like they're not always adding up, but most definitely, if you have a patient who had lost the weight, it's from nutritional insufficiency. And the list goes on. I really couldn't get it all in one page. Isn't that interesting? Sorry, to me it's interesting. What do patients and parents see? Almost always nothing, except maybe if the weight loss is so obvious, or maybe they're so irritable that the parents couldn't handle it anymore. Yeah, so maybe depressed mood, maybe anxiety. It is very rare that school is affected. Can you imagine, like, if you're the ultimate level of hangry and you're still managing to get a GPA of 4.0? Goodness, I'd feel really tired for that individual. Leaf feeding syndrome, we hopefully don't see this as outpatient. This is something that we would see while they're in the hospital when we start nutritional rehabilitation on a patient. So I talk about malnutrition or nutritional insufficiency a lot. If you've had the chance to refer patients to me, I reply diligently. And I apologize, there's a lot of words that I would put there, but one of the important things I determine is the degree of nutritional insufficiency. And this is calculated by comparing the BMI, current BMI of your patient to the median BMI, which is the BMI at the 50th percentile, because that helps me determine, can we safely proceed with nutritional rehabilitation as outpatient for the child versus inpatient. The other ways to determine the severity of NI is the BMI Z-score, or how fast they've lost the weight. And if I have the time frame, I'd compare, like, in the amount of time, the acuity of the weight loss. Okay. With those numbers too, I will project a treatment body weight. How do I do that? I would just get the weight intended for that median BMI for your patient's age and height. I don't expect people to, calculate this, but this is what I would really, I'm after when you make those referrals, so that I can appropriately say where we can treat your patient accordingly. Okay. This is a sample. Okay, I'm sorry, I put a pink growth chart here. This can be pink, this can be blue, meaning like you can do this for a boy or a girl. But just as an example, you have a female who's 14 years, 6 months, and the current body mass index is 14.5. Obviously, this is really low. This is less than the 5th percentile. Maybe this is the only number you got. Maybe you have other numbers on the BMI growth chart. But if I were to get the percent median BMI of this patient, I would, it would be, the median BMI is 19.6. So this would be 14.5 divided by 19.6 multiplied by 100. This is 74% median BMI. The severity of nutritional insufficiency would indicate mild, moderate, or severe. This actually would fall with moderate. The Z-score, you just subtract that current BMI to the median BMI over 2 standard deviations, because 2 standard deviations is where we would expect the normal curve for the BMI, and it's minus 2.5. The more negative it is, the worse. The treatment body weight, I would get the median BMI multiplied by the height, but in meters squared, and you get it in kilos. If you like pounds, then you multiply it to 2.2. Okay, this is what I'm scared of, to be honest with you. I'm always hoping that they would not meet criteria for admission, but that's not what I'm here for. Not to share my fears, yeah, but to educate people. Let us see. Okay, so this one, let me take care of that, yeah. The less than 75% median BMI for age and sex. And what if your patient has always been lower than the median BMI? We'll see where that would take us, but say lower or higher. Maybe they're not overweight, but they are hanging around at P80th all their life, or maybe at P25th. For hospitalization purposes, we want to stick with this. But I will really help determine, should we take the patient in versus do outpatient. That's not the only thing that we would consider, though. Yeah, if you check the vital signs and it's abnormal, they're like cold as ice. It's like Elsa. And and they have wide orthostatic differential, or maybe they already passed out in school or whatnot. They have electrolyte abnormalities because you did labs already, and you have EKG abnormalities. Or like their failed outpatient treatment, you really couldn't get a hold of the parents, they're so unreliable, or patients like on a hunger strike, I'm not going to eat when I go home. You know, we take into account these things. Or if they have, unfortunately, other medical conditions that will really interfere with their ability to get nutrition in. They're very depressed, they're suicidal, they're really not eating in the last 3 days. They're at higher risk for refeeding syndrome if they're like not eating at all, or they're very low weight. They have medical conditions that definitely will affect their ability, again, to have nutrition in safely. Okay, refeeding syndrome. This is scary because this can cause someone to die. Oh man, I'm so blunt. Anyway, the risk factors are really they're not eating, and they're very underweight, and they have acutely lost the weight. In the hospital, we are monitoring this. We expect this in the first week of nutritional rehabilitation, or more so, especially so if the patient's just not tolerating anything in, continues to throw up, refeeding syndrome would continue to be expected. How does this happen? It comes from fluid shifts. You get them to eat, there's insulin surge, and then you have cellular uptake of electrolytes and minerals, particularly of your phosphorus, because you know digestion is also a process, a catabolic process, and this will further decrease the phosphate levels of the patient. This can lead to tissue volume overload first, and then hypoxia in the tissues, possibly affecting myocardial function first, and then respiratory failure. I have never in my career let anyone get to this point. I think the worst that I have had experience actually is in our state, unfortunately. The patient was at 50% median BMI, was on a bedding thing, and she's in college. She was on a bedding thing with a friend who loses the weight first, faster. Came back home because she was emaciated, she could barely walk, and started eating at home. Got admitted to the hospital because of severe fatigue, couldn't really eat, but was trying. But because she was so nutritionally down, so very underweight, even just with a 600 calorie drink, she went into respiratory failure. Phosphorus levels at that time was 1.2. That is very low. Normal is at 3 to 4. This patient went into the unit. So that's the most severe. Usually when we admit patients in the hospital, either we, depending on the risk factors for refeeding, we empirically treat with phosphorus or the other electrolytes too. If because we're monitoring the blood work, if we're seeing refeeding signs, then we will not increase the nutrition plan and correct the chemistries too. This is where I need your help, I suppose. When you're thinking, okay, this is your patient has an eating disorder, the parents are not easy to work with, they're not paying attention to what you have to say. I want you to become familiar with what would happen when they get admitted to Kapiolani. And mind you, even if this patient goes to any other hospital in the state, because this is our children's hospital, they will be referred to our children's hospital. The refeeding protocol, or our NI protocol at Kapiolani, is very strict and is standardized. And the idea is to prevent the eating disorder behaviors from delivering the main medicine for the patient, which is nutrition, while also monitoring refeeding syndrome. It's a structured multidisciplinary care plan so that we have less variability in care. And this is evidence-based, like across the United States, North America. This is what is practiced. Actually, in Europe, or maybe Australia and New Zealand, their standard of care is actually tubing the patient so that you have less variability in caloric or nutritional rehabilitation, less chance of refeeding. In the United States, North America, we don't. We still let them actually eat by mouth, which I think has its benefits. Okay. The The meal plan, we typically would start at 1,500 to 2,000 calories. And we would do empiric treatment of refeeding syndromes and lab monitoring of refeeding signs, depending on the patient. But definitely, patients will be on strict bed rest. They will not be permitted to use the bathroom, not just because of the eating disorder, but oftentimes they are hemodynamically unstable. That even like having to use the bathroom straining, we're so worried that they're going to pass out. Variety of team, it's a team effort, most definitely. Nutritionist, me, psychiatry, social work, along with our hospital team. Okay, and sometimes we get whatever other complications the patient would be experiencing. We've had to have GI involved, nephrology. Once upon a time, we even have urology involved. We had a patient who had kidney stones. And that's actually, I think, from using laxatives. Okay. Oh, okay. Note that the food items will not be based on the patient's preference. Absolutely no vegetarian or vegan or outside food. We do not permit outside food because the food is the main medicine. We have to dose it accordingly. The ins and the outs are very much monitored, and we can't do that if the patient's family is bringing it in. The meals are timed and observed. We are conserving the energy, so the activity is restricted, and absolutely there is no discussion of numbers. Why do we do this? When they are at the point, okay, it's medically unstable, wouldn't it, you might think it might make sense to have the support of the family, get them to have the family bring the food. That will come in due time when the family would be better prepared. And that would take like the family getting educated as outpatient. Patients with distorted thinking or extreme hangry state, they will not have a good insight into their eating disorder. So even if I discuss the weight, I wouldn't know if that would be interpreted as, okay, I'm doing good because I'm losing more weight. I had a patient who has a severe anorexia nervosa. When I talk about just the trend of the heart rate, lowering trend of the heart rate, she was celebrating. Not she, but the eating disorder thinking in her was celebrating that. She revealed this to me months after recovery. The levels of treatment in the ideal world, when I have an inpatient and we're trying to medically stabilize the patient, the next step down is a residential eating disorder facility. You can imagine this as a boarding school. The patient is not at home. They would be 24/7 staying at a facility that will give them nutritional rehabilitation and psychotherapy. It depends if the family will be involved or not. When you talk to me, because the evidence for children, adolescents, young adults, the treatment for eating disorders is Maudsley method, which is family-based, meaning you get the family very involved. You teach the family how to meal plan and how to talk to the patient during meal times, because they're going to be the ones supervising that. So the residential treatment facilities, that would provide Maudsley. I would know. I would be a resource on that. I'm sorry, this keeps moving for me. Next step down is partial hospitalization. It's like an all-day school. Sorry, residential treatment facilities in our state, it is not available. The only one that has residential facility for our state is the IPONO program, which is in Maui, and their approach is individualized treatment. So this is, I would reserve this, I guess, recommendation. If this is an older adolescent who would have be more self-reliant and would have to know how to go about their eating disorder. If I have to really send a patient to a residential facility and they need Maudsley because it's a younger adolescent, it would have to be in the mainland. Sorry, continental United States. Partial hospitalization is an all-day school. Again, it's like all-day school, sorry, it's like 8 to 5. Sometimes it can be virtual. Also, we do not have this in our state. So if it were to happen, it would be in the mainland, and maybe if they have a virtual option for us here in Hawaii, they would be able to do that. What I have here, more reliably so, is our intensive outpatient programs. think of it as like an after-school program because you meet several times a week with the group and also individually with your nutritionist and your therapist. There are a couple in our state that would do modesly, meaning they would get the family involved, teach the family how to meal plan and not to give this responsibility to the child. And oftentimes, if we admit a patient medically, it's a really long preparation to get the family on board to like, hey, this is what's going to happen. You're going to have to do this. And we need you to pay attention on how important nutrition is, that you need to get this education from a program, from a nutritionist and a therapist that are really versed in eating disorders. This is because this is not any nutritionist or any eating program. How long do these things run for? The typical time frame for each step, actually inpatient medical stabilization can run from 4 weeks. I've had patients stay as long as 2 months. The longest I think was 4 months. Residential typically is approved for 10 to 12 weeks. Partial hospitalization is the same. Intensive outpatient program can last from 4 months to 6 months to maybe a year before you can actually do individual. The length of treatment for eating disorders for children, adolescents, and young adults, you have, as long as they're like getting the full treatment, meaning medical nutrition therapy, 1 to 2 years with very minimal risk of relapse. But if your patient is in and out, that, you know, patients can survive, can become adults, and they have eating disorders. Yeah. So the message you want to get to the families is that, you know, this is a very long journey. It is hard, but you have a good prognosis if you diagnose it early, you get the treatment early, and don't shy away from getting everything in. Just to have them like understand how difficult it is. And why do we do this? Because we know that, I'm surprised I don't have a slide, how eating disorders are still the deadliest of all the mental health conditions. Opioid crisis is second. Oh, wow. This is my take-home point already. Okay. When there is nutritional insufficiency, we can intervene, treat with nutrition immediately, and stop all the activities. It doesn't, you know, if they're like, oh, I have all these extracurricular, I'm not sleeping, or just have them really stop. Because the medical consequences of further weight loss or more nutritional deficiency are high. The longer you wait, patient might meet medical criteria for admission. The sooner the intervention, they don't have to go to the hospital and the recovery is faster. It's always important to get the family involved. Even if you don't hear back from me, you will hear about, well, you know, if you know of the nutritional rehabilitation places, it's always really okay to refer to them before me. I don't mind. I almost always, you can hear when I review the referrals, it's a simultaneous referral to the nutritionist, because I'm not just punting the referral to you, because I want your patients to hear how important nutrition is right off the bat. And then they'll hear that from me too. If they really would pursue the referral with me, they'll hear that when they call my office for an appointment. Oh, test questions. Should we go with this or should we do questions? I mean, I don't know, audience question.
Sorry, I didn't do the poll. Yes, go with this. And everyone can submit their answers in the chat.
That is so high pressure, you have to put it in the chat.
You can just message it to Summer.
Yeah, that's
so
fine
you
too.
don't have to feel bad about anyone else seeing your answers.
I'm teasing, I'm so sorry. There should be like the Jeopardy song playing. Am I supposed to read this out loud? No, I am. Okay. This is the persistent disturbance of eating, or eating related behaviors that results in the altered consumption of or absorption of food, and that significantly impairs physical health or psychosocial functioning, according to DSM-5. Is it A, eating disorders, B, gender identity, C, nutritional insufficiency, or D, body dissatisfaction? Can I go to second question?
They're still answering the first
Oh, I'm
question.
sorry.
We'll give them a couple. Sorry, my fault. I keep forgetting I have to do it after I log in, and I should have done it. We were sitting in here for so long.
You just tell me when then.
We have a majority of answers A and a couple C's. So if you'd like to go over the answer for question 1.
Absolutely. So anything that is like you cannot pinpoint what is going on with my patient. There's change in physical health, can't function, weight is going down, or maybe weight has been the same, or there's something not quite right with your eating habit. And there's that funkiness with the other things happening in your life. That's an eating disorder. The nutritional insufficiency is malnutrition. When you're actually like, okay, the BMI is low, there are abnormal vital signs. You can think of nutritional insufficiency as malnutrition. Okay. Gender identity is different. Body dissatisfaction is like what your patient will report maybe. I'm not happy with my height. I don't like my nose. It's not per se an eating disorder. Sometimes it's really just a growing adolescent noticing the changes in their body. But that can be considered a risk factor if you're already seeing like, eating habits that are different. Question 2, this is a hypothalamic response to malnutrition. A, low heart rate. B, less than 50 beats per minute. B is low blood pressure, less than 90 for systolic blood pressure, or less than 45 for diastolic blood pressure. Oh, wow, that's very low. C, increased QT, prolongation of your QT, C, or D, all of the above.
Keep going. We were enjoying the music.
If you say that, I'm just going to start singing.
We've got a lot of D's across the board. I think that's everyone got that one correct.
Yes, it's all of the above. Sometimes they're not all going to show at the same time. Yeah, so very good. Okay, number 3, when factors supporting hospitalization, A, abnormal and unstable vital signs. B, failure of outpatient treatment. C, comorbid psychiatric or medical condition that would limit outpatient treatment. D, all of the above.
All D's.
Correct. I agree with that. I don't know why B looked like it has a different color. It's not the answer. But yes, thank you. All right. Number 4, the following are the risk factors for refeeding syndrome. A, little or no oral intake. B, less than 70% median BMI. C, rapid weight loss. D, all of the above.
I'm also seeing all D's again.
Thank you. These are the answers. Okay, so I guess what I wanted to add here is that the refeeding risk syndrome, the higher it is, then the more likely that the patient will get admitted. So that's a determining thing that I'm always like wondering about when I get your referrals. Should I stop sharing slides?
Sure, go ahead.
Okay.
Well, thank you. That was fantastic as always. From my perspective, I'm always interested to hear a little bit more about what's happening outpatient, because as an inpatient doc, I see, the inpatient side of things, the frequent labs and the very regimented feeding plan and the contract that we have for families to sign to agree to all of the conditions and so on. I'm wondering if you could talk a little bit more about the transition, like that the way you talk with families about having to go into the hospital and how difficult it's going to be, and also maybe the sort of like emotional social part of transitioning back out of the hospital, because once we discharge them, fortunately we usually never see them again. And then also, of course, I don't know if I see a lot of PCPs here on this call, so I'm sure every single one of you has had more than one patient with an eating disorder. So we would love to hear what your experience has been, and especially if you have any thoughts on how to support them and their families best too. Thanks.
So here's the unfortunate thing. I've looked at the people that we have admitted to Kapilani since I came on and had the protocol. Maybe only 60% of them would actually follow through as outpatient. And almost always I wouldn't see the 40% anymore. To me, I think that could be so that 60%, if they go to outpatient, they follow up, there's a chance that they will recover completely, and they have. Not that 60% is not 100% of them, but most of them have. I try as much as I can. No, I shouldn't say that. I think that with our ability as clinicians, if we can get these patients to avoid meeting those factors to get hospitalized and to mobilize things as outpatient, that will actually be really a good prognosis for these patients. When they end up in the hospital, it's not because they don't get the care that they deserve. What we're doing is evidence-based, but because of the severity of the eating disorder had gotten to a point where they're hemodynamically unstable, I think that's where it really becomes very difficult for the eating disorder to be treated. The eating disorder, you cannot treat that when they're severely malnourished, when their brain starved, and it's really when you get them to be weight restored. And weight restoration for adolescents is a moving target because they're adolescents, they're going to grow. So it's really hard to get to that point. Oh my goodness, I just realized I have this and it's not even plugged in. Oh my Lord. Anywho, and yet you can hear me humming and singing.
We could hear you perfectly.
Oh, goodness gracious. Maybe now it's better. So, uh, when I see them as outpatient and they actually really hear, my recommendations through you, that they actually start nutritional rehabilitation. Oftentimes when I see them already, most of the parents are grateful because it's really hard for them to get like, okay, I can't get my kid to eat. But if they hear the message from their trusted provider, and that would be you, that would be you as the primary doctor, they would listen to you. If they get that recommendation from you, they pay attention, they get their kids to stop all exercise and actually start nutritional rehab, then life will be better. It's not easy. It's not a walk in the park. I don't promise patients anything, it's really hard. This is very life changing. If you have all these like extracurriculars, you have two parents who are working, how are they going to like sit down, feed this child with an eating disorder? It's very life changing. When I have a patient I'm seeing in my office from your referral, and even if they've done some of the things that we have recommended and they're meeting the factors for hospitalization, I tell them what to expect at the hospital. At the hospital, we can't help it now. You're at that point that you're hemodynamically unstable. We got to rest you out. It's going to feel worse than prison. And it's not because you're getting punished. It's because your body is in a state of, yeah, you can die from this, from severe malnutrition, if we let you do stuff like move around and about. Your heart situation is not going to get any better. It's going to get worse. And when we start feeding you, you're not going to like it, but we have to dose it in a way that is safe, because otherwise we get into this what's called refeeding syndrome, and you can actually be having heart failure or dysrhythmia. In order for us to safely monitor that, we go about blood work, and you're on a heart monitor. You will feel very weird and strange because we would not let the parents be with you when you're eating. Because parents, what you're going to see is your child's going to suffer. They're going to maybe scream, maybe not going to follow. You're not ready yet for that. Because we want to make sure that we're prioritizing food intake, we're going to do this with how your child is going to do it. And because food is really the main medicine, if your child's not getting it in by mouth, sometimes we would have to, the next thing is to get them to take Ensure. And if that's still not happening, we would have to feed you via NG tube. That's as similar as if you have antibiotics, but you can't take your antibiotics orally, then we would have a different route to deliver the antibiotics. They can be mad, they can talk and whatnot, but I would stress the importance of like how severe the nutritional deficiency is and how really medically important this is. And actually even telling them you're going to have behavioral health support, but I wouldn't expect any of you to be understanding how the behavioral health is going to be, like expecting that the person who's like nutritionally starved, brain starved, to respond to psychotherapy. Can TPN be used and how is it dosed? TPN can be used, but that's like the last resort, right? I've had the severe case of a patient, even with the NGT, threw it up, and JT still was throwing it up. And then we had to do TPN. That's very expensive. Yeah. But yes, it has happened. It will be dosed by our very brave hospital team. So I can only give when I have
Yeah.
anti-vertigo, I have the nutritionist speed diet. So wait, sorry, I would go with caloric intake, right? So that will be versed when it becomes TPN. That will be versed accordingly with the nutritionist and our hospital medicine team.
Yeah, I was just gonna say we can adjust that every day based on labs. So like give more potassium or more phos or whatever is needed, and then we get the caloric guidelines from Dr. Francisco and figure out also if they're able to take some orally, but they can't make the goal for whatever reason. Occasionally we get kids that have had really rapid weight loss and they end up with SMA syndrome. And so, and I think that was what happened, if I recall correctly, in that patient that we had who did end up on TPN, but I'm not certain. So, there are those occasional times when we have to do it, but luckily we have all the resources with a wonderful pharmacist to help us figure out our TPN. There was another question actually in the chat that I think was sent directly to us, Dr. Francisco. The person was asking about families who refuse meat for religious reasons. Is there any modification ever to that to the
If it's like
protocol?
absolutely, it's not like the kid change preferences for whatever reason, right? If it's really family. I've had a patient who had an eating disorder and it was Ramadan. Yeah, they're Muslim. And he was fasting. And you can't really like separate the two. Yeah, how do you go about that? Eating disorder programs can do vegetarian meals. I don't know of uh, uh, a good eating disorder program that will permit vegan. Okay, but for the hospital, no, that's an absolute thing that we have so far. Because almost always it would be a kid who's like, oh yeah, I changed my dietary habits like a year ago for whatever reason. But if it's really truly solid, that is based on religion, um, we'll probably, will as far as the hospital, that's probably um, the only time that it would be considered. Because, it's going to be difficult for you as the primary, yeah? In case like, oh yeah, we're all eating this way. Because they would always say things like this that would be very challenging. I have a really high approach to eating disorders because if you start catering to it, families don't realize this, yeah? It would have to be up to us as medical providers to actually really provide this care and why this is so. When they see me, this is not, again, it's not something that they would, you know, to me, it's really not negotiable because I am dealing with the minor, not dealing with, I'm treating the minor. And if the parents are saying whatever reasons why we can't deliver the food to the child, that is very problematic. And I've had cases where I would have to call CWS to get the parents to really follow through recommendations.
Thank you. That's really helpful. Folks, we have about 5 more minutes. Any PCPs want to chime in on sort of either challenges or successes that you've had with the transition into or out of the hospital, or any other questions that you might have for Dr. Francisco? Okay, no other questions, looks like. Thank you for a wonderful talk, Dr. Francisco.
Oh,
It's
no,
always
the
so
pleasure
good
is
to hear
mine.
from you.
Thank you so much for making the time.
Yeah. Maybe I will just close with a couple reminders. One is that we would love to hear from you about the time. A couple people were not here when we started, so I got one response that this time worked. But anyone else, if you would like to tell me, yes, this is great, or no, 12 o'clock was better, please go ahead and let us know in the chat, or shoot us an email or send me a text later. Our next session on the 16th. Oh, good. Kristen says this works better. So that's wonderful. On the 16th, so in 2 weeks,